All right, so today's session will be moderated by Dr. Shanila and Hamad. She is Khan University alumni. She graduated from the program of medical oncology in 2020, and she is currently working at her parent institute, which is AKU. So over to you, Dr. Shanila.
Assalamu alaikum, everyone. I hope I'm audible.
Yes, Shanila, you are.
Okay. So I welcome all of you in an educational session arranged by a club for young Pakistani radiation oncologists in collaboration with the G1, which is Global Village Oncology Network. So as I have been already introduced by Maria, I'll be moderating this session on febrile neutropenia. And today we are really honored to have Dr. Ikram Burney as a presenter for us. He's a senior consultant in medical oncology at Sultan Qaboos Comprehensive Cancer Care and Research Center, Oman, and a visiting faculty at Panjwani Center for Molecular Medicine and Drug Research, International Center for Chemical and Biological Sciences, Karachi University, Pakistan. He graduated from Liaquat Medical College, University of Sindh, Pakistan, and obtained his degree for a master's and PhD from University of London. He received his training in medicine and medical oncology at Hammersmith Hospital, London, Khan University Hospital, Karachi, Pakistan, and Southampton University Hospital Trust in UK. He worked as a consultant medical oncologist at Khan University Hospital from 1997 till 2003, and then to Sultan Qaboos University Hospital from January 2003 till August 2021. From August 2021 onwards, he's working as senior consultant in medical oncology at Sultan Qaboos Comprehensive Cancer Care and Research Center. His area of interest include lymphoproliferative disorder, genitourinary malignancies, gynecological malignancies, sarcomas, supportive care in oncology, and medical education. He has published more than 160 articles in peer-reviewed journals and has more than 1,000 citations at his publications. He is an associate editor of several medical journals as well. He is a supervisor of 4 PhD, 7 masters, and 3 postgraduate residents. His list of his achievements still continues, but in the interest of time, I would like to proceed with the session. For this, I would like to welcome Dr. Ikram Burney, and stage is all yours, sir. Welcome.
All right, so I would just I'm just trying to make sure that the participants have filled the pre-test form before Dr. Ikram begins.
Thank you very much, Dr. Shanila, for this very kind introduction and very generous introduction. Thank you very much. Thank you, Maria, and thank you, Hamad, for the invitation to share my views and my practice and my knowledge with all my junior colleagues in Pakistan. As has been introduced already, I worked in AKU for several years between 1992 and 2002. And it's really a pleasure to be back with most of you who are working in AKU or have worked in AKU, and also with those who are working in Pakistan as well. So it's really a pleasure for me. And I'm very honored that I was invited by the organizers of CIPRO as well as the G1, which is particularly Maria and Hamad. Hamad, as you know, now works over here for the past few months, and he is an excellent colleague whom I have the pleasure of working with. So my task is really to talk about the, if you allow me to share my slides now.
Ji, sir, we could proceed.
Yeah. Okay. So I hope we are there. And did I share the wrong screen? Probably. It's not moving. Just 1 minute, please. They all look the same. Okay. So this is it. There are no relevant disclosures to this particular presentation. And here are the learning objectives. By the end of the session, inshallah, all of yourselves would be able to, which you all probably already know, but it's just to list those things that you should be able to do, is to define febrile neutropenia, propose a plan of management for primary prophylaxis, appraise the risk scoring and stratification models, propose the initial management plan, suggest a management plan for follow-up of patients, and the importance of the education for the patients, as well as having the policies. Now, the format would be that I will present this case and I will ask a few questions in the interest of keeping it very interactive. And what I would really like is for you to just open your mic and shout, give me an answer. And I would like at least 3, 4, 5, or even more, or 10 answers for each question that would be asked. So here is the case. It's a prototype case. It's a case which you probably have seen yesterday already in your clinics, or you would see many times in your clinic in the next few weeks. Is a 52-year-old lady diagnosed to have a locally advanced breast cancer, which is estrogen receptor and progesterone receptor positive, HER2 negative, with a high Ki67, so immunotype B, was planned to be treated with neoadjunctive chemotherapy followed by wide local excision. So pretty much the standard of care. She is married with 2 children, is a resident, which is away from Karachi. It's about 60 kilometers away from Karachi. And she smokes bidi, and she's known to have chronic bronchitis, and she's on those medicines, salmeterol and ipratropium, which is very well controlled. So she was treated with a combination of doxorubicin and cyclophosphamide in the standard dose. And the first question to you, and this is in the first 1 minute, the question is coming to yourselves: would you use GCSF for primary prophylaxis? So I would wait 2 minutes and try to get as many answers from the participants as is possible and see what you think. Go ahead, please. Go ahead, please. You only have to answer yes or no. And if you want to, you can say why yes and why not.
Assalamu alaikum, sir. Dr. Fatma here, radiation oncologist from Karachi.
Walaikum assalam, Fatma.
Sir, in this scenario, what my opinion is that we won't be using primary GCF support, because this is the standard chemotherapy used in breast patient, doxorubicin 60 and cyclo 600 mg per meter square.
Yes.
So this is not dosed in regime or not docetaxel, where we have to use primary prophylactic treatment of GCF.
So Dr. Ikram,
Chances of getting febrile neutropenia in this scenario is very low. So what my understanding is, I don't practice chemo, but this is what my understanding is, that we don't give primary prophylaxis treatment in this scenario.
Sir,
How low is the low? You said the risk is very low. How low is that low risk?
Okay, so I don't know the percentages, but usually when I have seen patient with this chemotherapy, I haven't seen too many patients with febrile neutropenia present this chemotherapy agent.
Okay,
So
thank you.
I don't practice basically chemo, but this is my understanding. So
Yeah.
Assalamu alaikum, everyone. May I add something?
yeah.
I'm Dr. Mohammed Afzal, Dr. Ikram, a medical oncologist at South City Hospital. I'm postgraduate from Ahmad University Hospital last year. I started my consultant oncologist. So that she's not a diabetic, she's not having hypertension, and the usual dose of the chemotherapy that we have, no comorbids, age is less than 65, She has a good performance status, seems like. So I don't think so. Okay, we will prefer giving prophylactic GCSF support in this case.
Yeah. And what guidelines do you
Because
follow,
when there
Dr.
is a
Mohammed?
15% or more risk of developing febrile neutropenia.
Okay. What is the risk of getting
Sorry,
febrile
Dr.
neutropenia, Dr. Mohammed?
So more than 15%, if there is a more than 15% risk of febrile neutropenia, then one can consider giving primary prophylaxis.
Okay. Fair enough. I think those two answers would, unless you have got a different view, anybody has a different view, I think those two answers are both going in the same direction. Would anybody have a different view and a different explanation for not for using GCSF?
Sir, Shaila here. Also, the regimen that we are using, it's not in a dose-dense pattern, right? We are just giving the
True.
AC, which is a normal thing that we give. Secondly, the lady has a 52 years of age, not as Afzal explained, it's less than 60 years. I don't find any other reason to support the idea of giving her GC as a primary for prophylaxis, and overall AC comes in on like moderate. So and the less of febrile risk of febrile neutropenia is less than 20% in this. So for sure, we are not in with the opinion to give her as a primary prophylaxis a GCSF.
Very good. So you have used two figures so far. One of yourself, I think it was a doctor before yourself, she said 15% and you said 20%. So let's move from here and see what are the guidelines and how does it go. The NCCN guidelines are over here, and they are very, very clear that if the risk is 20% or more, then GCSF should be used for primary prophylaxis. If the risk is 10% or less, then the GCSF in primary prophylaxis should not be used. However, if the risk is between 10 and 20%, then there is a question and you need to look into so many other factors, such as the comorbidities and etc., so on and so forth. So let's look at it from a slightly different point of view. आप में से किसी का स्पीकर माइक ऑन है, सो जब आप बोलें उस वक्त अपना माइक ऑन कर लीजिए, वरना अपना माइक ऑफ रखिए. So there is a for primary GCSF prophylaxis. Okay, so the European Society of Medical Oncology has guidelines which are basically in conformity with the guidelines of the suggested by the NCCN as well, and which is more than 20% use GCSF, less than 10% do not use GCSF, but between 10 and 20% make a clinical judgment. And the clinical judgment, as some of you already indicated, is for people who are older than 65 years of age. But look at the comorbidities. Look at the various other factors that are listed over here, and which include obviously baseline cytopenias, the presence of chronic obstructive pulmonary disease, chronic liver disease, chronic renal disease, congestive heart failure, uncontrolled diabetes and hypertension, so on and so forth. So this particular patient, our patient, has chronic obstructive pulmonary disease. Although she is well controlled, but she falls in that risk category of between 10 and 20%. Now, the next question would be that, is the risk between 10 and 20%? And if you look at the chemotherapy regimens, which pose that risk of 10 to 20%, then doxorubicin cyclophosphamide is actually included in there. And there are some other regimens which you can see on the screen over there. For example, a combination of cisplatin with paclitaxel, docetaxel with cisplatin, or docetaxel with carboplatin as well, cisplatin etoposide, and even single agent topotecan and cabazitaxel. So these cytotoxic regimens, and you can look at the literature, you can look at some of the trials, the seminal trials, that the risk of febrile neutropenia here is between 10 and 20%. And that is where you want to make that sort of a clinical judgment, whether this patient falls into that slightly higher risk category. And if that were the case, then use GCSF. So because of the uncontrolled, because of the COPD, based on the guidelines, probably you would need to use GCSF in this particular case. GCSF is not free of side effects. Obviously, in Pakistan and in other countries, low and middle-income countries, one of the major factors to consider is the cost of treatment. But other than that, put aside, the cost of treatment aside, there are some important side effects which need to be kept in mind. GCSF can cause severe bone pains, particularly in the lower back, where the bone marrow compartment is. And these patients can have a severe and excruciating pain, which is only treated with non-steroidal drugs. And then obviously GCSF is not indicated at all in somebody who either has an allergic reaction or has got a ARDS. So I think those are two important contraindications which we need to keep in mind, although they are not relevant to our case. Now, my question, the second question to you is, since she comes from Thatta, since she lives about 60 kilometers away, and she has got COPD, would you prescribe her prophylactic quinolones to prevent neutropenia? This is a practice in some people, in some centers. Some centers do it. Would you do it? You can open your mic and tell us now. Go ahead, please.
Assalamu alaikum. My name is Dr. Ijaz from Faisalabad. So looking at the history of COPD and coming from a far-flung area, I would definitely go for 1 week prophylaxis of quinolone, ciprofloxacin or levofloxacin.
Okay, yeah, so you are basing your treatment decisions not on the guidelines, but based on the fact that she comes from a distance, which is fair enough. She's coming from a 60-kilometer distance, so you are basing your recommendations on that. Anybody else?
Sir, I will not recommend prophylactic quinolones in this lady, knowing the fact that she has established COPD. Considering the fact that I don't think this is a strong reason to start someone on the prophylaxis or quinolones. Unnecessary, resistance would be developing then. So I will not.
So what are the, if I may ask, what are the advantages of giving prophylactic quinolones from the medical point of view, from therapeutic point of view? Are there any advantages? Why some people use it and others don't? What are your arguments on either side? Anybody would like to suggest why it is used sometimes by some people? Okay, I think what I will do is I'll move on to the next slide to sort of give you that answer. And this is a question of open debate. And as you can see, there are more than 100 clinical trials published on the subject, and a meta-analysis on a Cochrane review published not too long ago, only 3 or 4 years back. It suggests the following, that there is basically no advantage using prophylactic quinolones. On the one hand, it would reduce the number of febrile episodes, the number of visits to the hospital. On the other hand, it has got a risk that it would induce resistance to subsequent treatment with quinolones, particularly if the same patient has used quinolone now, would not be able to use quinolone in the future when he or she needs it. So overall, the consensus which is emerging is that in selected patients you can, but in most of the patients you can't. And the most recent guidelines from the NCCN in 2022, I'm sure some of you would have a chance to look at those guidelines before coming to this webinar, is that for low-risk patients, which are basically all the patients with solid tumors, and you do not have major comorbidities which are which are not in control, there are no indications for either prophylactic antibacterial, antiviral, or antifungal medications. Now, having said that, patients who have got an intermediate risk, and I know that some of you treat patients with leukemia or myeloma or even an autologous transplant or allogeneic transplant setting, that is a different issue, but that is not the norm. That is only a very small percentage of patients where you do use prophylactic antibiotics, antivirals, and antifungals, but that is a different issue. But for most patients with solid tumor, the guidelines as well as the data, level 1 evidence does not support the routine use of prophylactic antibiotics. Is that clear so far?
Yes,
Okay.
sir.
Now, excellent. So we continue with the case. 9 days after receiving the first dose of cyclophosphamide, and this patient presents with a 1-day history of fever and rigors. And on examination, her temperature is 39.2, and she's tachycardic, but not hypotensive. She's in a usual blood pressure range, and her oxygen saturation is the usual for somebody with a stable chronic obstructive pulmonary disease, around 95, 96%. And the chest examination does not reveal any crepitations or bronchi. Now, the important questions to ask over here, anybody who presents to the emergency room, is, did the patient receive chemotherapy? And obviously you would ask this question. And this is so very important because unless you ask that question, the diagnosis would not become obvious. You also need to ask, how long back was chemotherapy given? Usually, if anything chemotherapy was administered in the previous week or so, and previous week to 2 weeks, there would be a very high index of suspicion for considering febrile neutropenia. And you would also want to know about the comorbidities as well. Now, once this history was taken, and there was a history of having received AC in 9 days prior, the results of the blood counts are shown, and the chemistry are shown over here. Would anybody like to comment on the blood results? Would anybody like to comment on the blood results, please?
So, sir, patient has a myelosuppression with the ANC, I guess, less than 500. And it makes her like having severe neutropenia, severe febrile neutropenia, because she was spiking fever as well. And other than that, I'm bad at millimoles wali calculation, so I'm so sorry whether it's in
I'm
normal.
sorry about that, but these are the calculations that I use over here, so I can sort of try and convert some of those. But let me tell you that creatinine is 72, so it is somewhere around between 0.8 and 0.9. And you probably know the sodium and potassium and the rest of it. And the liver functions are within the normal, bilirubin is within the normal range as well. So, yeah. So how would you classify this degree of myelosuppression? You said severe neutropenia, is that what I heard?
Yes, so it's I think, if I'm not bad at calculation, it's if I consider ANC, so it's less than 500, I guess. All right.
So this is severe neutropenia, and it could be called life-threatening neutropenia or protracted neutropenia if the counts were less than 200. But here it is 0.4 or 400, so it is severe neutropenia, and that is the definition. Between 500, less than 500, or 500 to 1,000 is called as moderately severe neutropenia. So that is absolutely right. And here are some of the definitions for you. So the neutrophil count, first of all, the definition of fever, I'm sure you all know the definition of fever. There's got to be one spike of 38.36 degrees centigrade, or 2 spikes of 38 1 hour apart without an obvious cause. that constitutes fever. Together with that, if the neutrophil count is less than 500, that is considered severe neutropenia. And or if the neutrophil count is dropping rapidly, for example, you check neutrophil count on day 7, for example, for some reason, and the neutrophil count was 900, and on day 9, the count drops to 600. Now you know that the counts are dropping very, very rapidly. So it's only a question of time and the count would drop to less than 500. That is also considered as neutropenia. So it's important to keep in mind that it's not only the 500 is the magic figure, but also rapidly dropping counts constitute neutropenia as well, and a patient should be treated in a very similar way as well. The first thing that happens when a patient comes to the emergency room with febrile neutropenia, you want to look for a focus of infection. Now, only in about 1/3 of the patients or a quarter of the patients would the focus of infection be obvious, and which is called as a clinically documented infection. For the rest of the patients, the clinical focus would not be there. The term is here, which is used, is also called as fever of undetermined origin. Although fever of undetermined origin usually is used for a certain different thing in textbooks, which is a fever which lasts for more than 3 weeks and which is the cause is not apparent even after extensive investigations. But here, I think it is important to keep in mind that the focus of infection would be identified only in a small percentage of patients. Now, the question is, where do you look for that focus of infection? People who are not very experienced or well-trained would probably do a very detailed examination and still miss out on some of the very pertinent areas of examination. So I've listed the 4 areas of examination here, which should never be missed in patients who present with febrile neutropenia. And those are, number 1, throat and the mouth. Number 2, chest. Number 3, site of IV access, which is either a portacath or a Hickman line or a PICC line or a site of previous catheter, cannula, and the perianal area, but keeping in mind, do not do a rectal examination because the blood counts are low and you can only introduce an infection by doing a rectal examination. But those 4 sites are so very important, and it only takes 2 minutes to examine those 4 sites, and you can move on from there to the next step. So those are the 4 most important sites for clinical examination. The initial management would be, first of all, to see whether the patient falls into a low-risk group or a high-risk group. And it's so very important nowadays to distinguish, because the management, although would be generally similar, would be with the use of empiric antibiotics, but the choice of antibiotics and the combination would be different. And as you would see in a minute, how else could it be different as well? So it's important to stratify the risk. Does anybody know about how do you stratify the risk? Would anybody like to comment? The tool that you use at the moment to stratify the risk of febrile neutropenia.
Yes, sir. As you have given this mask index, so we usually perform this at the time of patient present to us. And if the score is 21 or greater than 21, then we classify as low risk. And if the score is less than 21, then we classify as high risk. The high risk patients are admitted, and the low risk are may be treated as at outpatient.
That is excellent. If you are already doing that, you probably would not learn anything from the next slide, which is the Multinational Association for Supportive Care risk scoring system. And that is absolutely fantastic what you see. You look at myriad factors, which are all listed over there, which are the symptoms, the comorbidities, the age, blood pressure, and etc., so on and so forth. And you assign a score of either 5 or 3, depending on whether patient is markedly symptomatic or minimally symptomatic. and then you keep on assigning the scores. So here the score is in the right-hand column in the greenish color. You see the scores which I have listed for you, and the total score is 20. And you already said that the cutoff is 21. So I would not go into asking you which risk category does this patient fall into. She obviously falls into a high risk category, right? Now, having assigned the risk score, you also want to look at lots of other factors as well, which are probably not included in there in the MASCC scoring system, but you can also look at the risk stratification, which is a score of more than 21 or more, but also the fact that where did the patient develop febrile neutropenia? Was he or she at home or in the hospital? Whether there were any concomitant acute morbid illnesses or not, whether the anticipated duration of neutropenia is going to be more or less than 7 days. And then, generally speaking, if patients develop neutropenia early on, like on day 4, 5, or 6, they're expected or anticipated to remain neutropenic for a longer period of time. But if there is a delayed onset of neutropenia, for example, day 10, 11, 12, 13, then the duration of neutropenia is likely to be shorter. If the performance status, you also look at that, and you look at other factors, clinically relevant factors like hepatic and renal insufficiency, etc., so on and so forth, and the type of treatment the patient may have received. So based on all of those, you stratify the risk into low and high risk category. And as you said, the management of the low risk patient includes most of the patients, by the way, should still be admitted, particularly the patient that we spoke about, who comes from 60 kilometers away from the center, should be admitted, because if she cannot come back, that would be a big problem. So patients should be admitted to the hospital. They must receive antibiotics. They must receive antibiotics very well in time, within the first hour or so of them being seen. The question is, which antibiotic? Sometimes you can select these patients and give them oral antibiotics and keep them on oral antibiotics in the hospital and observe them. Most of the other times you would use intravenous antibiotic, usually as a single agent. And in very exceptional circumstances, you will allow these patients to go home. My suggestion is that unless you come to that level of experience and confidence, more importantly, confidence, that you can treat your patient, neutropenic patient at home, do not try that. The problem is, we are talking about Pakistan now. You let this patient go, he or she may not return the next day when things worsen. You may or may not be able to contact these patients on telephone. Their phone may or may not be accessible. They may or may not be able to tell you about their vital signs accurately. They may not have a thermometer at home. They may not be able to check their blood pressure and vital signs at home. And unless you can do all of those things, it would be very risky to allow these patients to go home, even though the risk of neutropenia is less. So you have to very carefully select your patients who can actually be treated at home. And from experience, they would be 1 or 2 out of 100. And that is very, very rare. The management of high-risk febrile neutropenia is obviously, and by far and large, by most of the patients would fall in this category. And as you can see, a score of 20 or 21 or less, most patients would fall in that category. So they would need to be admitted, and they would need to be treated with antibiotics. And the antibiotics, the characteristics of those antibiotics would be that they should be broad spectrum intravenous antibiotics. The discussion is usually, should they be a single or a combination, and which antibiotics, or the duration of antibiotics. So let me ask you a question. I've already given you some information that the antibiotics should be broad spectrum, should be intravenous, should cover the gram-negative organisms, and should have bactericidal activity. Would you like to name at least 5 groups of antibiotics which fall in this category, or the names of the antibiotics themselves. I'll wait now.
So we can have the imipenem or meropenem, which is a broad spectrum antibiotics. We can have cefepime or ceftazidime, again a broad spectrum antibiotics covering the pseudomonas and gram negatives, and a combination of the antibiotic, the combination of which tenzo, I think it contains a combination, and we usually prefer it in high risk.
Piperacillin and tazobactam, you mean? Tazocin.
Yes, sir. Yes, sir. Yes, sir.
Yeah, yeah. So what is any other group of antibiotics that you would like to, which falls in this category of broad spectrum intravenous bactericidal antibiotic? I cannot hear you well. Is it me or others are also having
Dr.
difficulty?
Tuba, your voice is pretty much interrupted. It's not clear.
Yeah.
The drugs we can use
No, we can't hear you properly.
Dr. Tuba, can you write your question in the chat box? I'll appreciate them.
While Dr. Tuba is writing, anybody else would like to suggest another group of antibiotics which you would use or can use? I've not heard of anything about aminoglycosides yet, unless somebody, Dr. Tuba is
Sir,
writing that already.
I was about to say this. This is aminoglycoside.
Okay, all
one
right,
of the
that's very
foreign.
good. Excellent. What
Right,
else
so
were
we
you
have
going
you
to
to
say?
test one.
Yeah. But you're also going to say, talk about fluoroquinolones as well. Intravenous ciprofloxacin, for example. So, would anybody else like to suggest a group of antibiotics? Shall I move on then? Can we move on? Okay, so here it is.
Yes, sir.
I give you a list of 5 different groups of antibiotics which are generally used in the management of febrile neutropenia. Aminoglycosides such as gentamicin or amikacin. Now I have to say something over here. So many times when I say aminoglycosides, I hear some people saying streptomycin. The streptomycin is an aminoglycoside, but not a broad spectrum aminoglycoside, and is given intramuscularly. So be careful over there. Beta-lactam antibiotic, which is a combination of piperacillin, tazobactam, and there are more now as well. For example, estunam, etc., so on and so forth. Carbapenem, somebody already said that. 3rd and 4th generation cephalosporin like ceftazidime and cefepime, etc., and the fluoroquinolones. So those are the commonly used antibiotics in the initial stages. Now, I have a suggestion for you. If you have not done it already, then working in different centers, please try to look at the bacterial isolates and their patterns of resistance in your own centers. It is so very important. If you look at any guideline, whether it is the NCCN guideline or the ITSA, the Infectious Disease Society of North America guidelines, or the European Society of Medical Oncology, all suggest the same thing. The choice of antibiotics should be based on the flora of your own area. Differences from one place to the other from one country to the other and from one society to the other. So the broad suggestions we have already given you, those 5 groups of antibiotics which fall into those categories, but which antibiotics to choose from there should be dependent on what you have. And I have just given you an example of some of the work that was done over here in the last 3 or 4 years, published last year. One of our fellows, working with me, he was a postgraduate resident for working for Oman Medical Specialty Board. And he came and I said, the most important thing that you want to do is to look at the patients with febrile neutropenia and look at their bacterial isolates. So he identified all of those. And as you can see, the vast majority in our place are still gram negative, 73%, and about a quarter were gram positives. And I think the more important thing is on the right-hand side, which is the patterns of resistance. And you see that there's a fairly high degree of resistance to tazocine, to meropenem, to cefepime, to ceftazidime, and ciprofloxacin. It's for this reason that in our center, we usually start with a combination, because after all, when you are treating initially, you are treating with empiric antibiotics, and you do not know whether this antibiotic would be effective against the organism or not. So you want to use a combination. If there is a resistance against one antibiotic, at least you have got the second antibiotic. And also because when 2 antibiotics are used, sometimes there is a synergistic action, particularly if you combine an aminoglycoside with either a beta-lactam or a 3rd generation cephalosporin, you get a synergistic action as well. So it is very important. And I think many of you can actually go back after this lecture, after this webinar, and tomorrow morning when you come back to your work, you can think of actually doing a very similar thing, is to look at the pattern of bacterial isolates and the resistance pattern and report it. And report it to the journals. This would give you a publication as well.
Dr. Wasim, can you please mute your mic?
So, okay, ma'am.
The next question that is oftenly asked is, how long should the antibiotics be continued for? Now, look, there were 2 indications for using the empiric antibiotic: fever and neutropenia. So if neutropenia resolves, the number of the neutrophil count goes beyond 500, and if patient achieves defervescence, then you can think about converting the antibiotics from intravenous to oral early on, and maximum of 5 days, and you can stop the antibiotics. However, if the neutrophil count remains less than 500, and then the patient becomes afebrile or remains afebrile for almost 5 to 7 days, then you can think of discontinuing the antibiotics. On the other hand, if the patient remains febrile despite despite a normal neutrophil count or a neutrophil count of more than 500 in this case, then you should never stop the antibiotics. You should investigate to look for a focus of infection. Generally, that would require a CT scan in addition to clinical examination, of course. That would require, you need to look for the occult foci of infection, such as the tooth abscess, such as the sinusitis, etc., so on and so forth, or intra-abdominal sepsis as well. In such cases, an ID consult should be obtained, and you should always consider the use of antifungals in these cases. If the neutrophil counts resolve, but the fever persists, there is a high chance that this would be almost a more than 30 to 40% chance that there may be a fungal infection, and you should be able to use antifungals in those particular cases. Now, the daily follow-up of these patients obviously require a close observation. Remember, febrile neutropenia is a medical emergency, and what you did yesterday was you started these patients on empiric antibiotics, but you still do not know the focus of infection, the source of infection. So you need to continue to look for those sources of infection and check the neutrophil count, of course. So clinical assessment should be done more frequently than the routine care. Routinely, in most of the hospitals, the nurses would check the vital signs once every 8 hours, which is once during their shift. But for febrile neutropenia, it should be more frequent. That's number one. The full blood count should be assessed on a daily basis, and up until you see a clear trend that the white cell count has gone up more than 500. If you see one reading, that is usually not enough. You need to have two readings because you want to make sure that there is a serial pattern of rise in the WBC. In case the fever persists, need to repeat the imaging and look for the focus of infection and modify the antibiotics accordingly. So in certain cases, you have to think of the fungal infections. What are the, once again, question to you, what are the two most common fungal infections you see in patients who have cancer or who have fever and neutropenia, prolonged neutropenia? Would you like to open your mic and suggest to
Sir,
me?
what I have seen so far, aspergillosis, invasive aspergillosis, and mucor. Because I saw
Yeah,
twice in two of my transplant patients, they had mucor.
yeah. So in transplant patients, those are by far and large very, very common. Anything else other than mucor and aspergillus?
So
Well,
candidal
the
infections?
yes, true, absolutely. So the most common infection is Candida. And Candida, whenever you say Candida, most people would think of Candida albicans, and that is where I have listed some of the other species which are very important to keep in mind when we talk about systemic Candida infection. Because Candida albicans, which constitute about 2/3 of all fungal infections in febrile neutropenic patients, but the rest of the infections like glabrata, Paralopsis, Krusei, or Tropicalis, these are usually associated with central lines. These are usually associated with hypotension, and these are usually associated with hepatosplenic candidiasis and invasive candidiasis. Aspergillus and mucor are also common. Now, if you look at Candida albicans, it is relatively easy to treat, as we will see in the next slide. But the non-albicans Candida and Aspergillus, they are hard infections to treat. It is very difficult sometimes to treat those infections. So once again, my question to you is, what are the common antifungals that you use in your patients who have a suspected or a proven fungal infection?
So fluconazole, amphotericin B, and what else? Voriconazole?
Excellent. Very good. Anything else? Very good. That's very good. So you can use azoles. You have given two examples of fluconazole and voriconazole, and you have suggested the use of amphotericin. Is there a third group of antifungal compounds which is now in routine practice and widespread practice? Azoles, as you know, have a propensity to cause liver dysfunction. Amphotericin is nephrotoxic. So if you have a patient, obviously these patients who are septic, have got neutropenic sepsis, can develop either liver or renal toxicity, and you want to treat them with something which does not cause so significant hepatic or renal toxicity, what would be a group of compounds there?
So the third group is echinocandins.
Caspofungin that we usually use.
Excellent, excellent, very well done. So here are the choice or your menu to choose from when it comes to the antifungals. As you can see, there are azoles. Now, fluconazole is probably the oldest of them all, other than amphotericin B. Fluconazole has been used. This is when probably even in early 90s or late 80s, and amphotericin B. So these are the two of the oldest compounds. The problem with fluconazole is that A, it causes hepatotoxicity. B, it is not a good antifungal for non-albicans candida or for invasive aspergillosis or mucormycosis. So there you want to use the more newer ones, newer azoles. One of them is itraconazole. The problem with itraconazole is that it competes with various other drugs at cytochrome P450, and there are lots of interactions even with proton pump inhibitors, H1 blockers, H2 blockers, warfarin, so on and so forth. So it becomes usually difficult to use itraconazole, but usually these days we use voriconazole a lot. So if you have to use an azole, voriconazole, or posaconazole. Posaconazole is the newest of the azoles. Amongst the fungins, we have Anidula fungin, which we use over here. I do not know in AKU and in other places in Pakistan what is the common practice, but this is something which you need to probably look for, find out, and you would probably know already. And then you've got amphotericin B. Amphotericin B is nephrotoxic, and if you are using other nephrotoxic agents like amikacin, or if you have used nephrotoxic cytotoxic agents, for example, cisplatin, high-dose methotrexate, ifosfamide, so on and so forth, it becomes difficult to use amphotericin. And in those cases, if you must use it, people use ambisome. Now, ambisome, or the lipid form of amphotericin, is horrendously expensive. It's one of the most expensive medications. You do use them in patients who receive allogeneic bone marrow transplant, in patients who have been treated with multiple lines for multiple myeloma, who are very immunosuppressed. You've got to use ambisome, but remember, ambisome is very expensive. So one of the alternatives now is the use of Anidula fungin, which is less expensive, or voriconazole, which is less expensive as well. Now, in the last few minutes, we will talk about some special situations, which is that by now, by 2 or 3 days, if you identify a focus of infection, or should you have identified a focus of infection upfront, what should you do? So if patient presents with pneumonia other than febrile neutropenia, or develops pneumonia while in the hospital, or is found to have pulmonary infiltrates, then what you do is you add a gram-positive cover. And the reason for that is that most of these pneumonias would be then caused by coagulase-negative Staph aureus, or by methicillin-resistant Staph aureus, and so on and so forth. And those are usually not covered with your initial antibiotics, such as tazocine or ceftazidime. Amikacin covers some of them, but not all of them. So you have to use an added gram-positive cover, such as either vancomycin or teicoplanin. And then you also want to add you may have to add a macrolide or a fluoroquinolone if you want to treat the atypical microorganisms such as Mycoplasma or Legionella. Obviously, patients who present with desaturation, you need to consider infection with pneumocystis and the presence of fungal infection, or occasionally in Pakistan, also tuberculosis. So I think patients who present with pneumonia pose a special challenge in patients who have got febrile neutropenia. And that's where your early intervention and early discussion with the pulmonologist about the possibility of getting a bronchoalveolar lavage is very important. It is usually not possible to get a bronchoscopy because patients are also thrombocytopenic at the same time, but a bronchoalveolar lavage is usually possible, and lavage can help direct the type of treatment, because the possibilities are so many. Possibilities are a resistant gram-positive infection, a resistant gram-negative infection where you want to know the antibiotic, pneumocystis jirovecii, or fungal infection. So you just need to identify what is it that you want to treat. Try to get the organism early on through a bronchoalveolar lavage. Patients who present with diarrhea or with intra-abdominal sepsis, they need anaerobe cover. Now, when we were speaking of antibiotics, you know that tazocine and meropenem are very good antibiotics for anaerobic cover as well, in addition to the gram-negative cover. But if patient is on other antibiotics, for example, ceftazidime, like third-generation cephalosporin, or quinolones, then they do not cover anaerobes. And in those conditions, you may have to add metronidazole as well, intravenous metronidazole. Particularly if the patient has diarrhea, do not give oral metronidazole, nothing would be absorbed. So these patients require that. Persistent diarrhea also require estimation for Clostridium difficile infection, I'm sure you would be able to check that in your laboratories. C. difficile is not uncommon. These patients would have received antibiotics on multiple occasions. So check for C. difficile. And if that is the cause, then the treatment is either with oral vancomycin or intravenous metronidazole. Would anybody like to suggest which one is better in terms of rapidity of onset and the control of infection? Is it oral vancomycin or intravenous metronidazole?
So I have seen patients and ID people to prefer oral vancomycin over IV metronidazole. I may be wrong as well, but I have seen the patient recovered really well if you consider oral vancomycin in such patients.
Absolutely correct. And
That's
that
my
is borne out.
opinion.
No, your opinion is correct. Your opinion is based on evidence. Your opinion is based on evidence, and you should look at the evidence as well. For this interest of time, I did not put all the evidence over here, but oral vancomycin is better in terms of the response rate as well as the rapidity of onset as well. So if you can use oral vancomycin for the treatment of C. diff infection. And then many patients with cancer would be receiving their chemotherapy through Portacath or Hickman. And I think it is very important to know this, that first of all, it's part of your initial examination is to look at the chest wall to see whether they've got a Portacath or a Hickman, because that would be a focus of infection. Sometimes the infection occurs at the site of the insertion of the Portacath, called the pocket site infection. The infection may occur along the wall of the catheter into the internal jugular vein, called the tunnel site infection. Although there is a small silicone hub which prevents infection from going all the way, but nevertheless infection can occur there. But more commonly, the infection would be intraluminal, which is you would only get with the blood culture. So there are those three basic sites of infection: the pocket or the tunnel, or the intraluminal infection. If it were a pocket infection or a tunnel infection, the Portacath or Hickman line must come out, because otherwise you would not be able to treat the infection in the skin only with intravenous antibiotics. So that is one thing. You should be prepared to remove the Portacath or Hickman line if you were to treat the sepsis. If it is a culture obtained from the blood, you need to know what did you obtain. If it's a coagulase negative Staph aureus, you can treat it with intravenous vancomycin or teicoplanin given through the Portacath. But if it is any other infection, like a Pseudomonas or like a fungal infection, then still the Portacath needs to come out. What happens is that these infections, they form a very fine biofilm inside the lumen, and they would keep on showering the emboli from there. And unless you remove the Portacath, it would be impossible to treat those infections. So it's important to know what was identified from the Portacath. And a practical point over here is that when you take cultures, you must take a culture not only from Portacath, but also from the peripheral line as well, from the peripheral blood as well, because you need to know whether it's an infection which is in both places, from the peripheral vein as well as from Portacath, or it's only from peripheral vein, which makes a difference, because it would be treated differently. So if the organism is identified from both sides, you know that the infection went through from the Portacath, and now it is in the peripheral blood as well. And that must be treated with removal of Portacath if it is Pseudomonas, any gram-negative bacteria, or a fungal infection. I think the last slide before one, I need to speak about something which is equally important as the medical management of febrile neutropenia, is patient education. You can have patients as partners for their safety. Patients should be made partners for their own safety. Patients should be educated. They should be educated about symptoms, including monitoring of the body temperature using a thermometer. Now, how many times do you know a patient actually is being treated for chemotherapy and has a thermometer at home? If that is not the case, how would they know that the temperature is more than 38.3 degrees centigrade or more than 38 at any given point in time? So always tell the patient to buy a thermometer, keep it at home, and use it, and come back to you if there is a temperature in excess of 38 degrees centigrade. There should be very clear instructions to the patient, who to contact, how to contact, where to contact, the phone numbers, etc. They should always be given. The other day, Dr. Hamad and myself, we were talking and about one of your other very good things that you are doing at CIPRO and GWON, which is to develop patient information leaflets and patient information sheets, especially in languages that are spoken by your patients. So for example, there should be a patient information leaflet not only in English, but get it translated in Urdu and Sindhi and Punjabi and Pashto and Saraiki and Balochi, because your patients read those languages. You can also think about, later on, please. Thank you. You can also think about making a small little video clip or an audio clip which you can send to your patients on their smartphones as well. So there are lots of ways of engaging patients in their own safety by giving them clear instructions. Other than that, there should be your emergency room. You should pay frequent visits to your emergency room. Find out what does the emergency room doctor know about the management of febrile neutropenia, because chances are that when the patient comes with fever, the emergency room doctor may not be here in this audience over here, but they are the ones who would be asking those questions. Did you receive chemotherapy? When did you receive chemotherapy? Let's check a blood count on you and let's do a quick clinical examination. If emergency room doctors are not aware, then it would delay the diagnosis of febrile neutropenia and sometimes even cause bigger problems, because emergency room doctor may tell them, take paracetamol, go home and see your oncologist tomorrow. That would be an absolute disaster. Then within the hospital yourselves, there should be an antibiotic policy. You have seen there are 5 different groups of compounds: aminoglycosides, 3rd generation cephalosporins or 4th generation, beta-lactam, quinolones, and the carbapenems. Within aminoglycosides, there is gentamicin and amikacin, and there is a difference between the coverage of the two. Some hospitals, there are about 5 to 7% are resistant to amikacin, but about 20% are resistant to gentamicin. In other hospitals, still only 5% or less are resistant to gentamicin. So we should know what is your antibiogram at your hospital, and based on that, there should be a policy, and that policy should be known to everybody, that should a patient come, you do not start thinking how to treat, but you treat according to the policy, because this is a empiric use of antibiotics. It's important to communicate with microbiology. It's important to have your friends in microbiology. You pick up phone and ask them about the gram stain and the culture, and the sooner they give you results, the better it is. You should not be worried about ID consultation. Try to involve the ID team soon, and similarly the pulmonology team as well. In case of pulmonary infiltrates, the bronchoalveolar lavage should be done sooner rather than later. So to summarize, and I think we are coming to the end of the presentation now, febrile neutropenia is an oncological emergency. Primary prophylaxis with GCSF should be administered if the risk is more than 20%, and also if the risk is between 10 and 20%, but there are comorbidities, as was in our case, and this is borne by the NCCN as well as the ESMO guidelines. Secondary prophylaxis is different. A patient who develops febrile neutropenia should be treated with secondary prophylaxis if they do that once, or if they are getting dose-dense chemotherapy, or if they are getting if they have got several comorbidities or routine or baseline cytopenias. Routine use of prophylactic antibiotics is not supported by guidelines, especially for low-risk patients, which includes all patients with solid tumors. One should keep a very low threshold for the diagnosis of febrile neutropenia. Risk stratification should be done. This risk calculator is available free. It's online. It should be on your mobile phones, on your smartphones, and you should be able to use it all the time. So this is important. Just download the app and it would be available to you. Knowledge of the bacterial isolates in your own institution is important. and you can actually get a paper out of it as well if you like. The low-risk patients should be treated with a single-agent intravenous antibiotic or an oral antibiotic in the hospital. The high-risk usually require a combination of antibiotic. The threshold for consultation should be low, especially with microbiology, ID, and pulmonology. And you think about developing the policies as well as material for patient information as well. With that, I thank you very much. Now, I have asked you so many questions. Now it is your time to ask questions. So I'll stop there and I'll take your questions. Thank you very much.
So I
Right, sir.
encourage
Thank you.
all, okay, I encourage all participants to please ask as many as questions that have you in mind, because it's one best opportunity to ask Dr. Ikram directly. So over to the participants.
Can I remove my slides so that I can then see you as well? Stop sharing the slides. Is that okay? Or do you want to go back to some of the slides?
No, sir, that's okay. That's fine. So while the
Okay.
participants are
All right,
thinking,
so
Maria, you can ask.
yes.
Yeah.
So first of all,
I
sir,
will
I would
appreciate
like
if
to thank
Shanila or Maria can read the questions for me because it would be easier for me to answer those questions rather than reading them from the chat box.
Yes, sir, sure. So, sir, first of all, I would like to thank you for a wonderful talk. It was really an awesome talk, and I just do not have enough words to thank you for the knowledge we have gained today. Because as radiation oncologists, we usually do not see this in our routine. So it was really fruitful for us, and we have
Thank you
received
very much. Thank you. I'm
we have
very
received a
happy that
couple
it
of
was useful.
questions. All right, sir. Thank you so much. We have received a couple of questions from the participants. Dr. Shanila will be sharing that. Thank you, Dr. Shanila, for a very fruitful interaction that went throughout the talk. I have a small question before Dr. Shanila can moderate for the other questions. And my question is that how often do you see splenic rupture and capillary leak syndrome in patients who are on GCSF?
Capillary leak syndrome in patients with solid tumors, very, very little. Splenic rupture, if that happens, write a case report about it. It's exceedingly rare. But bone pains, I can tell you that 1/3 to 1/4 to 1/3 of the patients would develop bone pains, especially if the blood counts go up to beyond 4,000 white cell count. At that stage, it's very important to keep in mind that if patient is on GCSF, to stop GCSF and use ibuprofen. So the complications that you spoke about are fairly rare, actually. But having said that, let me just add one thing, and I think I did indicate there as well. Use of GCSF in patients receiving drugs which are toxic to the pulmonary cells, alveoli, should be done with huge caution. So I avoid, and many people actually avoid using GCSF in patients receiving bleomycin, because it's known that patients who receive bleomycin and develop acute lung injury, if they are given GCSF, they can have these premature white cells which clog the pulmonary vasculature and can induce temporary hypoxia and can even lead to a picture like ARDS as well. That is not quite capillary leak syndrome, but that is something which can cause hypoxia and could be an issue as well. So that should be kept in mind as well.
All right. I would also like to thank Dr. Ghulam Haider, who is the head of medical oncology at JPMC. He was also connected
I
with
didn't
us.
realize that Ghulam Haider was there as well. Assalamu alaikum, Dr.
Yes,
Ghulam Haider.
yes, sir. He was with us a while back, and Dr. Yasmeen Rashid was also connected with us. She is medical oncologist at Khan University. She has a comment.
Assalamu
Dr.
alaikum,
Burney,
Yasmeen.
thank you for
So nice to know. Yeah.
Dr. Burney, thank you for the wonderful session. At AKU, ID team shares this information about Institute's antibiogram and patterns of resistance each year in a booklet form. So this was the comment by Dr. Yasmin. Dr. Nadeem Abbasi was also connected. He just left for Asar prayer. He has also a few comments that pertinent practice tips very well covered and elaborated by our expert speaker, Dr. Ikram. We cannot thank you enough. With the permission of Kipro, I wish to make a comment regarding an innovative idea for brainstorming and mashwara from all the Kipro and G1 colleagues, especially Ikram Bhai. Thanks a lot. Very much grateful. We are witnessing a very positive change in Pakistani cancer care patients via skill development and educational services like you are offering, sir. So thank you so much. Dr. Shanila will be taking over and sharing all the questions that we have received so far.
So, sir, I have 4 questions. The first one is, especially from my side, that how would you manage or advise the ER people in which where the patients after soon after induction landed with the febrile neutropenia, and when at that time they are just done with their induction in hematological malignancies, and they ask you very frequently that whether they should give a start GCSF in such patients. uh, at that moment, would you be worried about the MRD of the patient?
You mean ARDS, acute respiratory distress syndrome?
No, sir, my question is a patient who has a, say, for example, AML, and after induction, he landed at ER with febrile neutropenia.
Yeah.
So, whilst in starting GCSF in such patients, would you consider the MRD thing, or were you worried about the MRD in such
Minimal
patients?
residual disease. Okay, right.
Yeah.
Thank
yeah.
you very much. Yeah. Okay, thank you. Shanira, this has always been a theoretical concern that GCSF or GMCSF can stimulate the stem cells and cause a relapse of leukemia. I do not treat acute leukemia anymore for the last several years, but I actually happen to have reviewed that data several years back and more recently as well. There is no evidence to support that that actually happens. However, patients who are not in remission from their leukemia should not be treated with GCSF, and this is the ESCO guidelines as well. And these are the NCCN guidelines. But patients who have entered remission after induction chemotherapy for acute myeloid leukemia, there is evidence to support that GCSF actually shortens the duration of neutropenia in conjunction with the when used in conjunction with the antibiotics. So I have not seen anything of recent which says that patients with acute myeloid leukemia in remission cannot be treated with GCSF. I hope that answers the question.
Yes, thank you. Sir, so what I got that in patient who are MRD positive, the use should be avoided, but always it should be risk versus benefit. What kills patient earlier should be treated first, rather thinking about the disease relapse and so the second question is pretty much related to that. If with the post-transplant patient, if the disease relapses and the patient has low ANC with a fever, which is febrile neutropenia, in addition to his or her primary treatment for the underlying cause, would you like to add GCSF upfront?
Upfront, yeah, that's a very good question. And that is a practice probably in many places. When you see a white cell count which is slightly low, for example, a neutrophil count of 400 or a total leukocyte count of 900 or so, there is a tendency to give GCSF to improve the white cell count. This is all cosmetics. This doesn't help. If you look at the guidelines, there is not supported by the guidelines at all. The GCSF, the guidelines are in primary and secondary prophylaxis, full stop. People also use GCSF off-label in conjunction with the antibiotics when patients have febrile neutropenia, because that reduces the duration of neutropenia by 2 days, as I just said. Other than that, this question of using GCSF for cosmetic treatment of the white cell count is not supported by guidelines.
All right, sir. Probably the last question that I have, that you mentioned that neutropenia, ANC, when it is less than 1,000, right? In AQ, but we practice that we usually avoid dose and therapies in patient, like the therapies that are anticipated to cause more and more myelosuppression, we usually have a cutoff of 1500 rather less than 1000. So if I say someone that you should avoid giving chemotherapy when the counts are even less than 1500, I'm not talking about the weekly regimens, I'm just talking about the Q3 weekly one. So how will I like justify my statement at what time? At some time I'm saying that the ANC and the neutropenia will be when it is less than 1000. On the contrary, I'm saying that you should avoid giving chemotherapy when it's less than 1500. So where to guide someone? So
Yeah.
there is no way in between.
Yeah. Okay, thank you very much. This is a very important and a practical question, and I think it requires a little bit of a explanation. Obviously, as you said in the response to the previous or the question before, there has to be a risk-benefit analysis. If you wait for the white cell count to be more than 1500 and then treat, you might that might lead to dose delays, and that might lead to a reduced dose intensity as well. So it depends on the situation that you are treating your patient in. Is the patient in a palliative care setting receiving palliative chemotherapy, or is the patient in a curative setting, such as for a germ cell cancer of the testes, or for Hodgkin lymphoma, or for a small cell cancer, or for breast cancer, or colon cancer, and so on and so forth? We know already that maintaining dose intensity is paramount, and reducing the dose intensity may actually lead to impairment of survival as well. Now, for some protocols, you might treat if the white cell count is more than 1000, and if the platelet count is more than 75,000. You don't have to wait for the white cell count to be more than 1500. And this information is available on the with the protocols all the time. That for some protocols, for some combinations, you can do that. For some other combinations, you cannot. It's also important to know what drug you are using. Some drugs would cause early neutropenia, and others like topotecan or, for example, melphalan, etc., they cause delayed neutropenia. So the neutropenia occurs, for example, from day 14 to day 21, rather than, as with most other compounds, it would be from day 7 to day 14, that sort of a thing. So it's important to know the drugs as well. By far and large, you want to balance what you are treating and what setting you are treating in. In my practice, I can tell you the following, that for germ cell cancers, for Hodgkin's lymphoma, and anybody that I'm treating in curative setting, the total white cell count of more than 1000 and an absolute phagocyte count of more than 500 would be fine, and we can continue with the chemotherapy, of course, keeping an eye on the neutrophils. Now, in such cases, although you are not treating them in a dose-dense fashion, which is every 2 weeks, but then there would be an indication for the use of GCSF in subsequent cycles so that you achieve a normal count before day 21 of the next cycle, and keep going like that. So you have to make judgments, basically, most of the times in these settings.
All right, sir. The last question. This is the last question, sir. As you mentioned that if the patient's afebrile and ANC is less than 0.5, patient has no complication, we may consider discontinuing antibiotics, right? The same question is for GCSF. If the patient has less than 500 counts and is afebrile, has no complications, would you recommend the use of colony stimulating factors in such patients? And that's the last question I have.
Yeah, no, you can ask as many. It depends on. I'm fine with time. Yes, I mean that's another very good question. Is that if despite GCSF therapy for 5 to 7 days, the white cell count is not increasing, there's got to be a reason. Usually, for example, in leukemics, that's because of bone marrow infiltration. Even in some solid tumors, that may be because of bone marrow infiltration. In certain other cases, that may be because of bone marrow infiltration or or hypoplasia induced by the previous chemotherapy, so on and so forth. So that would require investigation usually. What I said was that in patients who have defervesced after a few days of antibiotics and whose neutrophil count continues to be low, you can wait 5 to 7 days, and if they remain afebrile, you can discontinue antibiotics. The GCSF, you need to make decisions as to why the counts are not coming up. And if the reason is one of those things that I stated, then investigate the cause and treat.
All right, sir. So I have one question in the chat that she's asking that suggestion about using L-Thrombobag in patients who present with thrombocytopenia along with febrile neutropenia after chemotherapy for solid tumors.
Okay, so I must confess that I have not used L-Thrombobag here. One of my colleagues has, but I usually do not use it, so I would not. It would not be fair to answer that question.
So one question from my side, sir. What's your preference regarding the short use of GCSF, like 300 microgram per day, or versus the long-acting one, sir, 6 milligram dose?
Yeah, very good. So for primary prophylaxis, both are equally good. Whether you use 300 micrograms subcutaneous for 5 to 7 days or 6 milligram intramuscular on day 2, both are equally good. Obviously, one looks at the convenience of the patient as well. If they have to go to the center or to a local health center many times to get GCSF, I think there's very little to choose between the two. It depends on the convenience of the patient.
All right, sir. So I think we are done with the questions. There are some thank you notes for you in the chat by Dr. Sana Naveed, by Dr. Saleha Kamal, and by Dr. Bilal Mazhar Qureshi, who is our section head of radiation oncology. He is thank youing for an excellent practical review. And I would also like to introduce a participant who has connected all the way from USA, Dr. Noman Malik. He is a radiation oncologist. He has done his residency from University of Toronto, Canada, and currently he is doing his fellowship at University of California, San Francisco. So I would like to thank Dr. Noman Malik for joining this talk all the way from USA, given the time differences. Thank you, Dr. Noman. And I would, in the interest of time, we are already quite ahead of what we were targeting. I would like to thank the scientific committee, which included Dr. Shanila and Dr. Agha Muhammad Hamad Khan, and the organizing committee, which included me, again, Dr. Agha Muhammad Hamad Khan, and Dr. Fatma Shaukat. And there's a long list of the people who have been supporting me and Dr. Hamad in this cause, including Dr. Bilal Mazhar Qureshi. And for today, a very special thanks to Dr. Uruba Jawad Rao, who is a G1 member. She was running today's recording, and she made the pre-test and post-test sessions for today. I will be sharing the post-test for today's session in a while. And I would like to invite Dr. Bilal Mazhar Qureshi for the vote of thanks. Dr. Bilal, are you there? I think Dr. Bilal is not here now. So Dr. Hamad, can you please do the vote of thanks?
Thank you very much, Maria, and thank you, Dr. Ikram, for your guidance, especially related to G1. And just at the end, I would like to take this opportunity and invite all of you to please join our cause in order to improve patient care in Pakistan. So, Dr. Rafiatur is one of the senior colleagues with us, joining from Nouri. And thank you very much. And sir, बहुत बहुत शुक्रिया आपका और बाकी I hope that when we finalize all the things, we will circulate in all social media platforms regarding the G1, TAF, and KIPROS. And our main focus is our patient and how to improve. Thank you all for connecting.
All right,
And
so
especially thank
everyone,
you,
I
Dr.
am
Khan.
posting the post test in the chat. Please fill that.
Thank you, Maria.
Thank you, Dr. Hamad. And
Okay.
thank you, Dr. Shanila, for a wonderful and interactive moderation today. And Dr. Ikram, I do not have enough words to thank you. We as radiation oncologists, we have learned a lot, and I am speaking this on behalf of every radiation oncologist who is connecting it. It was volumes of knowledge for us today. Thank you.
Thank
It
you,
was
Maria.
my pleasure to be with you all, and it was indeed so nice, and it's so nice to have you for you to have invited me to this. Thank you.
Thank you so much, Dr. Kram. It was an amazing and interactive session, and truly speaking, I enjoyed every bit of it. So, and I was also excited, like I would be able to interact to one of the, ex-faculties of AKU in medical oncology. So it was equally, excited, and the thing was amazing experience for me. Thank you.